It's my pleasure to introduce Kevin Kavanagh, who is the founder and board chairman of Health Watch USA, a nonprofit patient advocacy and healthcare policy research organization. And I just realized he's associate editor of the Journal of Patient Safety. So, Kevin, welcome.
Well, thank you very much. I'd like to talk to you today regarding preventable hospital mortality. And if you take home nothing else from this lecture, please remember these 2 points. One is that we know far too little about this subject. And the other is that what we do know is that preventable hospital mortality occurs far too often. No one is really counting. The medical profession was largely silent after the 1999 Institute of Medicine's report, which estimated that there were between 44,000 and 98,000 preventable hospital deaths each year. In 2013, a NASA scientist, Dr. John James, a father who lost his child to medical error, published an updated estimate in the Journal of Patient Safety. This estimate is both widely criticized and praised, but I think we need to take note that most importantly, it took a patient advocate to refocus medicine on this problem. Dr. James estimated that there were between 210,000 and 440,000 preventable deaths each year. He based this on 4 studies which used the global trigger tool to identify adverse events and weighted these studies based upon the size of their N. In 2 of these studies, preventability, however, was not determined. And in one study that didn't determine preventability, it was stated that 100% of the deaths from adverse events should be considered preventable, and that was the figure that was used. The Leapfrog Group in 2016 estimated that there were 206,000 preventable deaths each year. They used a total of 16 publicly reported metrics to establish this estimate. These included methicillin-resistant Staph aureus, Clostridium difficile and other healthcare-associated infections, 3 healthcare-associated conditions, and 7 patient safety indicators. McCary and Daniel in 2016 estimated in BMJ Open that there were 251,000 preventable hospital deaths each year. They based this on 4 studies, which they weighted equally, and they also made the observation that this high of a rate would make preventable hospital deaths the 3rd leading cause of death in the United States. Myself and a number of patient advocates published an estimate in the Journal of Patient Safety of 163,000 preventable deaths each year. We also reviewed the literature on this subject. We based our estimate on 2 studies which used the global trigger tool and determined preventability, and we weighted these studies based upon the size of their N. Now, all of these studies used vastly different methodologies. There was some overlap of the data sets, but they all came up with numbers which are unacceptably far too high, over 100,000 preventable hospital deaths every year. The reaction to these publications was surprising. Dr. John James's article spurred a spokesperson from the American Hospital Association to state that they did not agree with using the global trigger tool to determine and detect preventable hospital deaths, and that they were going to stick with the Institute of Medicine's figure of 98,000 preventable hospital deaths each year. Now, I found this to be pretty telling and surprising, since in my view, this was a hospital spokesperson from a major hospital organization that essentially stated preventable hospital deaths were far too common, being 98,000 deaths per year, and there was no appreciable improvement in over a decade. The main reaction that I have heard to these publications has not been a renewed commitment to invest more resources in patient safety, but instead, it's been the generation of a myriad of excuses justifying the status quo. Since its inception in the mid-1980s, the Anesthesia Patient Foundation has promoted innovative techniques for the prevention of adverse events and the prevention of deaths. And in part, they have emulated and adopted techniques of the aviation industry. So what I'd like to do today is to look at some of these excuses I have heard and relate to what goes on in the aviation industry. One of the most common is that, well, causality wasn't proven. The error occurred, but it didn't cause the fatal event. Well, in the airline industry, all factors are found and corrected. Proving causality is not required. Severe events are not mitigated, but they are dealt with seriously and corrected. This is also true in other fields of science, such as in geology and paleontology. In this month's issue of The Atlantic, there's an excellent article called The Nastiest Feud in Science. And this is over what caused the extinction of the dinosaurs. Was it caused by volcanoes or was it caused by an asteroid impact? Both events occurred. Both events were extinction-leveled events. So I have to ask, why does one event have to be responsible? Why can't they both be responsible? Why don't we concentrate on the event and don't worry so much about the outcome? I will hear the excuse that it's the patient's fault because of poor life choices. The patient smoked, the patient drank, the patient was overweight. But if a traveler wishes to travel between Washington, D.C. and New York City and chooses to go by train, and that train has a fatal preventable accident, is his death discounted because he made the life choice of traveling by train instead of the safer mode of transportation, an airplane? No, it's not risk adjusted. It's the event what is concentrated on, and that is what is important, because if you don't correct the event, the fatal and tragic outcome will be repeated. I will also hear the excuse she was very sick and old and had only a short time to live. And this just makes I can't tell you how often I've heard this, and it's not a good excuse. And again, in a fatal airline crash, you never hear the airline company discounting the deaths because some of the passengers were old and frail and would have died soon anyways. No, they concentrate on the error. That is what is important. I will hear that it's a very hard and complex case. Again, in the transportation industry, some of the travelers fly long legs of travel with multiple takeoffs and landings and have complex itineraries, which place them at higher risk for an adverse event. But they're not risk adjusted downward when a fatal airline crash occurs. They focus on the event. So one of the important messages of this talk is that preventable errors must and should be separated from the context of the patient. It doesn't matter what the status of the patient is. We need to concentrate on the error, or that error will repeat itself and may in the future have a more tragic outcome. I will hear the excuse that, well, European and Canadian studies have shown that our medical profession is doing quite well in preventing errors. In fact, that was a major theme at a keynote speech at the National Patient Safety Foundation. Well, this is like comparing apples and oranges. The United States healthcare system is fragmented. What goes on in one hospital doesn't necessarily go on in another hospital, and these type of extrapolations are not valid. In the airline industry, we do not use data from foreign carriers in airlines to measure the safety record of the United States airline system. Full disclosure is extremely important. In the airline industry, all events are disclosed which cause harm. If you park your car on the side of the road and someone hits it, you would expect that to be fully disclosed, that the person would leave his name and address. Hit and run accidents are not tolerated. They are illegal. Only in medicine is this debated. I've read an article on the ethical dilemmas of full disclosure. In no other area in our society is that behavior tolerated. Now, the numbers I quoted may well be too low. Who commits the error is important. If a fatality is caused because of a government approval of an unsafe drug and device, that's oftentimes wouldn't be counted as a hospital fatality. Diagnostic errors have been contributory factors in up to 5% of hospital deaths. But again, those are not counted. And 90% of adverse events can be missed in studies which base their estimates solely on volunteer reporting or patient safety indicators. We can and we must do better. The Leapfrog Group estimates that 33,000 lives would be saved if all hospitals performed at a similar level as their highest group of functioning hospitals. In our healthcare system, we have little standardization. Just this July, AHRQ took down the National Guideline Clearinghouse, and I feel that this was a huge step backwards in patient safety. Our healthcare system has an aversion to checklists. Too many hospitals have a poor working environment. and too many hospitals have understaffing of nurses. If you look at the causes of adverse events, the two major causes that are most frequent are pressure ulcers, accounting for 32% of adverse events, and drug reactions, adverse event reactions, which account for 30%. And believe me, anesthesia falls into the category where that piece of the pie is extremely important. Now, detractors will state that there are a little over 700,000 deaths each year in hospitals, so how can the numbers be that high? Well, if you don't believe the number of 200,000, what about the low range of the Institute of Medicine's figure of 44,000 preventable deaths each year? Is that too many preventable deaths? Or how about 10,000 or 5,000? What would happen to an airline company which had 5 preventable deaths in a year and refused to acknowledge them or change practices? I would predict that they would be out of business. So I'd like to close and leave you with this old ancient Chinese proverb, is that if we do not change our direction, we are likely to end up where we are headed. Thank you.